webinar. I think you're going to get some great pearls out of it. So please feel free to ask questions. The point of this webinar is taking you from when you approve your treatment plan with us to finalizing your patient in the least amount of appointments with the least amount of refinements. And if we can get them to 0, we'll get them to 0. And with the least aggravation for you, for your staff, for the patient. So for those of you who don't know me, my name is Sofia Arauz. I'm a general dentist. I graduated from the Universidad de Panama. That's where I'm originally from. I also completed a GPR in my home country, and then I completed an AGD residency and an AGD fellowship at the University of Connecticut. I was very honored to be offered a full-time faculty position as clinical faculty for the AGD residency, and also as faculty for the dental anatomy and morphology course for the dental students. I have also held some positions within the dental industry as coordinating CE, the latest one being Medical Affairs Senior Scientist for Sensodyne and Pronamo. And now I'm very glad to be part of this great company as Director of Scientific Affairs. I do really think that what we're doing here is the future of orthodontics. So please feel free to ask your questions. We're going to have allocated sections for your questions. Please know that I can't see the screen. So I can see my own screen, but I can see the chat. So if you do have any questions, please voice them at the allocated times because I won't be able to read your questions. So our agenda tonight, we're just going to go real quick over why the whole anatomy, the whole orthodontic anatomy, as I'd like to call it, matters for orthodontic treatment and how we implement that at 3D Predict. And then we're going to talk about how to complete your case in only 6 visits or less. And also we're going to touch on IPR. We're going to touch on auxiliary elements, including attachments and refinements and other considerations at the end. So why roots and bone matter for orthodontics? And I think most of us in the audience are general dentists. We know roots and bone matters for anything else in dentistry, right? It's very hard to think of any dental specialty that doesn't take into account the whole tooth and the alveolar bone. And so why would that be different in orthodontics, especially because we're moving those teeth within the alveolus. So it's very hard to know where we're gonna go if we don't know how we're starting or where we're starting. That's why I like our company icon, the iceberg tooth that you see here, because when you're looking at the crowns, when you're looking at the 3D model that other companies give you back that you can only see the crowns, you're actually just seeing the tip of the iceberg. It's very hard to make clinical determinations, at least sound clinical determinations, when you don't have the whole story. Now, this is a good example of a case of when that matters. This patient seems periodontally sound, reasonably periodontally sound, but you see this patient has ortho relapse. This patient might show up in your practice requesting clear aligner treatment to treat the relapse. You probably would not think twice about treating this patient, but the reality is if you take a CBCT and you see this in the right image, you will see this widespread dehiscency pattern that is tied to orthodontic treatment, especially when we do uncontrolled expansion. And so what this, at least for me, will definitely change my treatment approach. I will probably not feel comfortable treating this patient without a periodontal referral, or at the very least having a conversation with the patient and thinking about what our plan of action would be. So in here you see to the left, this treatment plan, you're doing some protraction of those incisors, and then you're retracting a little bit just to correct the crowding. Now, it doesn't seem like anything groundbreaking, but when you actually look at what's happening within the bone and with the roots of the teeth, you see you're causing this widespread dehiscency pattern that I was talking about before. And this is what at 3D Predict, we try to give you all this information to prevent getting those unwanted results. Now, the second reason why roots and bone matter is because you get stable, predictable results. Here you can see the comparison of the last step of the treatment plan, what we predicted was going to happen versus the CBCT scan 1.5 years after treatment of this patient, and they look basically the same. And the patient has not experienced relapse. What about artificial intelligence? You probably have heard us talking about that. You have heard other companies talk about that. It is a buzzword nowadays. A lot of people use indiscriminately, but at Treaty Predict, it actually means something to us, and it will be able to explain that to you so you know what's the benefit to you and your patients. So we have a proprietary software that is called Deep CBCT Analysis, which includes the real crowns and roots and bone of your patients. So the way this works is you submit the STL file or a PVS impression, you submit a CBCT scan, and in return, you not only get the crown module that you usually get with other clear aligner companies that you're used to see, but you get a bone module that you can see here, which gives you the width of the cortical plate from the root of the tooth. And it's a color map. So the more red you see, the less width you have, the more blue is the more width. And then you have the root module, which gives you the movement of the roots at every aligner step. So you can check the angulation, you can check if they're leaning towards the sinus, you can check everything that is happening with those roots until the end of the treatment. Now, to the left, you can see we're making some movements to correct this crowding, and nothing really seems to be the matter when you look at the crown module, but when you look at the root module, you're gonna see that actually at step 18 out of 22, you get root collision between those two incisors. Now, root collision is a big issue, is one of the main reasons for mid-treatment refinements. So we're never going to give a treatment plan where you're going to see root collision, but know that that's because we are checking the root and the bone module and preventing that from happening. Now, also, because we take into account your patient's full orthodontic anatomy, like I said, and because all of our treaty plans are reviewed by orthodontists before they get to you, 74% of those treaty plans are approved in the first iteration. So we save you a lot of time in that back and forth with the technicians. And also, we allow you to make decisions based on the whole information, like I said. For example, this doctor wanted distalization to correct this malocclusion, and then a little bit of retroclination of those anteriors. Now you can see this caused this to be a very lengthy treatment, 40 steps, and also caused dehiscence of those upper anteriors. The doctor was not happy. We actually suggested to the doctor, let's check the treatment tactics. Let's do a little bit of expansion and a little bit proclination. And this actually addressed both of the doctor's concerns. It actually cut the treatment time by almost half, and it reduced the dehiscence considerably. Now, what about if you don't have a CBCT? Because we do have a lot of clients without CBCT. Just know that we have been doing this since 2014. So we have an extensive database of CBCT cases that nobody else in the market has, which means that out of the 14,000 clinical cases that we have completed, roughly 40% of those cases are CBCT cases. So our software has learned from these cases what could lead to a refinement, what actually we need to prevent combining when it comes to movements. What movements can we combine and to what extent? For example, how much amount of distalization with how much amount of rotation we can combine to actually make that treatment faster. Not because we're making the movement faster, but because we don't have to finish one movement and then start another. We're actually combining those movements. So even if you don't have a CBCT, you're going to see the benefit because our software, our data set has fed the machine. Because of this, we have a lot less refinements, as you can see here in expansion, rotation, and our cases are completed faster just because we have the AI and we don't need additional appliances for a lot of the movements we're doing because we know, like I said, where we're starting, so we know where we're going. Now, just to give you a little summary of what I said, if you submit a CBCT scan and you submit a PBS impression or an STL file, we're going to give you the crown module that you're used to, but we're also going to give you the bone module and the root module. If you don't submit a CBCT scan, you get the benefit from the AI, and we're going to give you a crown module. We wouldn't give you a root and bone module. Here at 3D Predict, we believe in showing you reality. We don't believe in showing you cartoons. We don't believe in showing you stock images from a book. We want you to feel confident that we're being honest and straightforward with you. And so if you submit a case without CBCT, you would not see the roots on the bone of the teeth, but know that you are still gonna get the benefit from the AI. Now, as a summary, I think I have made it clear why roots and bone matter in orthodontics. Also, we incorporate that into AI, whether you are submitting a CBCT or not, to give you safer, more predictable, faster results. And because all of our treatment plans are reviewed by orthodontists before they even get to you, and because of the AI, we save you time, and 74% of those cases just are reviewed in the first iteration without the back and forth. So any questions on our company before I jump into the main topic for tonight's presentation? Okay, let's keep going. So how to complete treatments in 6 visits. And this might seem, not a reality, but it is real. We can actually do it. A lot of our cases are completed even in less than 6 visits. So the key to do this is these steps that I'm gonna go through one by one. Obviously, diagnosis and records are key. The prescription, the communication with the technicians, how do you review that treatment plan to make sure that it's aligning with your goals, compliance of your patients, how many visits you have with your patient, the visits, planning the visits is key, and also retention after treatment. So obviously, accurate diagnosis, records is important. This is a picture from the American Board of Orthodontists. I suggest you give this to your staff, they study it. Having accurate pictures is key. A lot of the doctors ask us, why do I need pictures if I'm submitting scans? I'm gonna show you that in a second, but having intraoral, extraoral pictures of your patients really allow us to give you a treatment plan from the beginning that is gonna be the most accurate. Now, obviously, STL files, PBS impressions without voids. The machine can fill some of the voids, but if the voids are too big, it turns into a guessing game, and it definitely reduces the accuracy. Please always try to get the second molars. Even if you're not doing the sterilization, it's important because we might be placing attachments on those molars for retention. Get the whole bite on both sides. Sometimes when you scan one side, the scanner tricks you into thinking that they can complete the other side. Not, as we know, molar classes are not the same sometimes in both sides. So it's important to capture both sides without voids. And this goes back to my first point. Please take pictures, take scans. It's a point of comparison because sometimes, as you can see here, the bites don't match in the scans and the pictures. And this happens quite often. And then it comes into the question of what actually is the patient's bite. And in this case, you can see it's a very tiny difference, but the difference is there. Is the bite open in the canine or is not? And this makes a huge difference if we're gonna be closing that bite. And then we need to go back to the doctor and ask doctor, which one is the bite? And some doctors even tell us, well, pick one. And in reality, that's just gonna lead to refinements, is gonna lead to even mid-treatment refinements, more trays, more visits, more chair time. That is just completely unnecessary. So just make sure those pictures and those scans match. And if you want to see more information about pictures, show it to your staff or whoever is taking those scans, whoever is taking those pictures in your practice, please go to your doctor account on their manuals. We have all that information there. Now, accurate diagnosis and records. We have a case selection table. It's very extensive, as you can see, between how you should pick your treatment plan between predict short, predict super short, deep CBCT, predict full, right? And deep CBCT and predict full, the only difference between those two is if you have a deep CBCT, if you have a CBCT or not, obviously. Now, we can make a lot of movements with deep CBCT predict full. Some doctors think, well, if I am just gonna do less than 15 steps, then I should submit for predict short. That's actually not true. In predict short, for example, we would not be able to align the midline because the amount of movements to align the midline probably are gonna exceed 14 steps. So even though you might think you need 14 steps, we might have to come back and tell you, doctor, predict short is not gonna do it. And for example, in predict short, we wouldn't do extrusion. It would only be with predict full dip CBCT. So feel free to take a look at this chart. This is under the manual section 2, but also your sales rep has this printed out. They can provide you a copy. Now, the short version of that I want to show you tonight, and feel free to take a screenshot of this because this is going to come in handy. This is nowhere else, is this summary here. So for predict super short, if you have relapse, orthodontic relapse, up to 4 incisors, whether it's upper and lower or both upper and lower, it's probably predict super short. Predict short, which is less than 14 step, is if you have relapse from first premolar to first premolar, if you have a spacing that needs to be corrected then less than 2 millimeters, and if you have crowding that needs to be corrected less than 2 millimeters. Now, predict full is everything else. Crowding more than 2 millimeters, correction by protrusion, class 2, class 3, open bite, deep bite, anything else that is not predict short, predict super short, please submit it as predict full or deep CBCT. The second point is to focus on your prescription. And the first part of your prescription is your clinical preferences. So if you go to your doctor's account and you go to your profile, you're gonna see a section that says clinical preferences. So if you have clinical preferences for all your cases, for example, some doctors said, I never wanna place attachments on first step. I never wanna do it. It just causes more issues for my patients with removal or insertion of trays because we're adding more retention, obviously. Then if you want us to place attachments on all your cases on step 3 to give that patient a little more time to get used to clear aligners, then please put this on your clinical preferences. And we know that for every case, we're gonna do this. Same thing for IPR. Do you wanna perform IPR? Don't you wanna perform IPR? And if you wanna perform IPR, are you okay with starting it on step 1 or do you prefer to do it later? Also, are you okay with expanding? Are you okay with not expanding? There are some doctors that don't want to expand at all. And in this case, you can see this particular doctor, because this is a real doctor's account, is telling us he wants to avoid expansion as much as possible and try to keep everything within anatomical boundaries. Now, please complete your prescription. We have made these 2 fields mandatory because they were left blank a lot of times. And if you don't complete anything else, at the very least, we need this completed. What is the clinical condition of your patient? What is your patient's chief complaint? What is your main treatment goal? Because we know, we can actually give you the best occlusion ever, but it might not be the amount of trays that you want. It might be a lengthy case, a lengthy treatment, that's not what you were looking for. You might not be looking to correct the molar class, but we wouldn't know that until you tell us. So here, for example, these are good prescription examples. And here we're seeing the doctors giving us all this information about he wants an implant, us to leave a space for implant number 19 equal to the width of tooth number 30. The same situation here, the doctor is actually telling us, I want this implant space to be 7 millimeters. We can make the calculation for you, but sometimes you may want more or less. So if you have a specific number in mind, please let us know. So in here, you can see the doctor is very detailed about patient wishes to have completely aligned and stay straight anterior teeth. Why? Because they had ortho as a child. So we already know this is a relapse patient. Here, patient wants to keep molar in place. So we're not correcting the molar class right away. The doctor is telling us only wants anterior maxillary teeth to align in position. Now, the third step is with communication with your technician. So after you submit your prescription, your technician is going to come back with comments. Sometimes doctors go directly to the 3D plan. They skip reading the comments from the technicians, and then they don't understand, well, why wasn't my prescription follow? Or I didn't request this. And sometimes the technician is telling you that on the comments and clarifying for you. So in this case, for example, the technician is saying, we could not achieve perfect occlusion, which is Andrew's 6 keys of occlusion, because we could not do the distalization that you requested since the third molars are still in place. So that goes back to the first point of diagnosis and case selection. In this situation, in this real situation, the doctor was planning on extracting the wisdom teeth, but because that wasn't communicated in the prescription and the doctor wanted the sterilization, the technician could not give the doctor that treatment plan because the technician didn't know the wisdom teeth will be extracted. So that could have saved a back and forth if the doctor will have clarified that in the original prescription. And in here, you can see, for example, the technician is saying, we extruded tooth number 11, but that causes recession. Please let us know if this is acceptable or you would like to change your treatment plan. And one that is very common, please notice that this specific movement causes the teeth to go outside of the bone. Now, we're always going to try to keep your cases within anatomical boundaries. With that being said, we're also going to follow your prescription. You are the captain of the ship, and that trumps everything. So if we are following your prescription and that causes dehiscence and fenestration, and you can see that in your treatment plan, please know that we're just following that prescription, but we're letting you know that that is causing a periodontal issue. Because sometimes doctors that we work with are okay with those treatment plans because they're planning on perio surgery after the treatment is completed, but we wouldn't know that. And then the fourth key to finishing your case in 6 visits is a thorough 3D plan review. And this has 5 steps in total. You can find these 5 steps again in your doctor account under manuals if you want to review them. But I'm going to go through it real quick. This is actually a different webinar, but this is going to be very quick. So the first step is reviewing the root and bone module. If you did submit a CBCT, okay? So you want to make sure that at the end of the treatment, you feel okay with the amount of dehiscence and fenestration, if there's any, or any recessions that you might see, and the bone condition, and the width of the cortical plate. As you can see here, we're giving you the key of that width. The second is reviewing the occlusion. Is the molar class what you wanted? Is the canine class what you wanted bilaterally? Also, you want to see the occlusal model here. How is that occlusion looking at the end? Do you foresee you're going to need some occlusal adjustments? Is everything balanced? Is everything what you wanted? Now you're going to be checking the overbite and the overjet as a third step. And please always look at from the lingual too, because that's how you're really going to be able to see the overbite. And then we're going to be checking the upper and lower alignment. Please use the grid that is here. Every square is 1 millimeter. So you can see in the incisors, are they aligned? Are they at the same level, including the laterals? Are they both at the same level? Everything here looks good. And obviously do the same for the lower arch. And finally, we can see here that you're going to see the arch form, which is part of the alignment. And then you're going to see the path of movements. So you're going to go back to the root and bone module if you did submit a CBCT, And then you're gonna go step by step, going back and forth. Is there any movements that you don't feel comfortable with? Is there any amount of dehiscence that may be at an initial step or middle step that you may want us to tweak? Please let us know. And obviously, always take a look at the amount of the steps your case is taking. In this case, it's only 10 aligners. The doctor was happy with this. But if you don't want to go past certain amount of steps, please let us know here. It's always important to take a look at that. Now, the fifth step is patient compliance and visits. And I know there's a lot of train of thoughts out there. Some companies say, please change, you can change aligners every 7 days. Some other companies say, change aligners when the next step fits. We at Treat to Predict, we follow publications, we follow the science. It will be, we will want to make doctors happy by saying every 7 days. Obviously, treatments go faster, but that's actually not scientifically sound advice. Based on publications we have reviewed, it is clear that the best outcomes, the most predictable outcomes, is when your patient is wearing those aligners for 14 days. 14 days, and they're wearing them for 22 hours per day, minimum 20 hours per day, and they are not lowering that number. Now, with that being said, the reason for this is because when you stop wearing your liner less than 20 hours per day, then the osteoclastic activity stops and it doesn't resume until you start wearing your liners for another 48 to 72 hours. So even if your patient starts wearing the liner the next day and they wear them for 22 hours the next day, it's gonna take a good 2 to 3 days for that bone remodeling to start taking place. And this leads again to refinements, this leads to case note tracking, and this leads to extra visits. So please know that, like I said, we have reviewed the literature. There's a lot of literature out there from great journals that makes very clear that it has to be, in this case, a 15-day period, but a 14-day period minimum of wearing the aligners. And now how you're gonna plan those visits, and we're gonna talk about this later on when we're going to IPR and refinements and so on. But a good tool for you to plan the patient's visits is, when are my patients due for IPR and attachments? And how you're gonna know this is when you look at your PDF report within your treaty plan. This PDF report is also included in your first aligner case as a printout. So this is a PDF report. In the PDF report, you're gonna see a lot of information. At the very beginning of it, you see how your patient started, the movement chart, and then the finish. And then we're gonna go into the legend, which tells you, this is, for example, place, when it has a plus sign, place attachment, just check the attachment, change it, remove it, etc., etc. And then we just detail you the steps where you have to see the patient physically. So in this case, for example, which is a step 1, the provider is placing attachments on the molars, is placing attachments on the canines, is placing attachment on this lateral and on these canines and on these molars. And they're also performing IPR in all these interproximal spaces that you can see here. And we're gonna give you the amount. Now in step 11, what the provider is gonna do is they're just checking those attachments, and that's the reason for this visit. And at the end, we just give you a degloss of all the movements that are gonna take place per tooth, right? With the particular legends for each movement. And now the last key to success to finishing your 3D planning 6 visits is retention protocol. This is, once again, a journal article. It's very well known why you need to have retention, but please keep your patients in retainers. after you finish treatment. It is important, whether it's the retainers you can acquire with us, whether it's retainers that you acquire outside, it doesn't matter. It is the key to success to have your patient in retainers. For how long? Some doctors say for life. Some doctors say 2 years. We really are not gonna make that decision for you. The literature is really, it's all over the place. Some cases are very successful after only 2 years. Some cases are very successful the whole life. I personally feel like the more movement that happen, the longer the patient needs to be in retention. So if you corrected a class 3 or a class 2 molar, I will probably keep that patient in retainer for a lifetime if possible. Any questions at this point? Okay. Well, feel free to let me know if you have any questions. By the way, this is a picture of Panama City. Now we're going to be talking about IPR. IPR is a hot topic. A lot of doctors don't feel comfortable doing IPR. We're going to talk about, is IPR detrimental to your patients? We're going to touch on that point because I know it's a good question. It's a question we get a lot. And also doctors don't feel comfortable performing IPR. We're not taught that in dental school. I understand that, but there's a lot of tools out there to help you. So why is IPR important? And there are 5 main reasons. Obviously, to gain space, I think we can all agree on that when we have patients with crowding. To correct and prevent black triangles. To gain a space for predictable intrusion and rotation. And this goes ties to the second point, actually. To reduce the amount of distalization and mesialization, which is going to shorter your treatment plan. And the last one is to achieve class 1 when there's posterior tooth side discrepancy, Bolton discrepancies. So the first point is to gain space to predictably treat that crowding. So this patient has severe crowding. In this case, we did rotation of 27, 22, 26, up to 29 degrees, I believe. And then we did some torque or some angulation of 29 and 20 up to 30 degrees. And we expanded quite a bit. We expanded 5 millimeters on the premolars. And then we expanded 2 millimeters on the molars. This case actually took 20 steps. As you can see, this was a big difference for this patient. And you can see the retainer at the end. But how did we came up with that amount of IPR that we did? So in this case, the provider created 2 5 millimeters of IPR. And the way we determine the amount of IPR is based on whether it's a CBCT case, we base it in the alveolar bone. If we take it, but if it's not a CBCT case, then our technicians take the case, set up the case, and they first try to gain space by doing expansion. If expansion is not enough via angulation, then they do bodily expansion of the teeth. If that's not enough, then they go and analyze Ponce index, which is a way of analyzing space. I think some of you may remember that from dental school. And then that way, if there's a discrepancy in the size of those teeth and there's still not enough space, that's when we actually add the IPR. So the point that I'm trying to make is that we just don't do IPR from the beginning. We try to gain space any other way, obviously by respecting the anatomical boundaries, first of all. But if there's still not enough space, then we will need IPR. So we always add this strictly necessary IPR because we know enamel is precious and we would not be taking out enamel if it wasn't strictly necessary. So in this case, actually, the IPR was also added to correct black triangles because as we know, those lower incisors are triangularly shaped. So when you correct the crowding, you might have those black triangles. And that's why sometimes that interproximal reduction is needed. Now that goes linked to my second point, which is to correct and prevent the black triangles. In this case, you can see in the movement data chart that you find in the PDF form that I showed you before, the rotation of 26 and 25 was quite a bit, 15 and 14 degrees. This will probably lead to black triangles after the correction because of the shape of the crowns. And in this case, the technician added IPR to change the shape of the incisor slightly to correct the black triangles that were already there for this patient. The third reason for IPR is to gain a space for predictable intrusion. So tying back to the previous point, when you do rotation, right? When you have a tooth rotated, we know most teeth mesiodistally are wider than buccolingually. So when you have a tooth rotated, it might be occupying less space in the arch. And when you put it in position, it is occupying more. The same thing goes for intrusion. Obviously, these incisors, this upper anterior incisors are less wide when you look at closer to the cervical margin than when you're looking at the incisal edge. So when you're intruding those teeth, you are requiring more space. So in this case, IPR was needed to provide that space for this intrusion. As you can see, this case was completed in 19 steps actually for the mandibular section, and for the maxillary was completed in 22 steps, which is pretty good considering that we did 2.7 millimeters of intrusion for number 3 actually, which is very hard to achieve. Now, this is just another view. As you can see here, the amount of IPR that was needed, which was really not that much if you think about the mesiodistal width of those teeth that we needed to accommodate for both arches. And this is the final result. Now, take into account that for this final result is pre-restorative because this patient actually had veneers done after the treatment was finished. Now, when treatment includes intrusion and rotation, like I said, it is necessary to check the interproximal contacts between incisors and reduce them as needed. So even if we didn't give you IPR, or even if we gave you IPR, if there's intrusion and rotation in your case, know that your teeth are gonna need a lot of space. So it is important that every visit that you have the patient in the chair because you're changing attachments or you're doing IPR, you're checking those interproximal contacts. If the floss is not going through or if it rips, you might need to reduce it just a little bit with the strip, like you will do when after you do a composite. Not too much, just enough for the floss to go through. The fourth reason to do IPR is to reduce the amount of distalization and mesialization. Obviously, if we do IPR, we need to move those teeth less. And the fifth reason is to achieve class 1 in case of posterior tooth discrepancy. We do Bolton analysis, which is the analysis we always do when we're setting these cases. Like I said, one is bond index, which gives us the amount of expansion that is needed. Then Bolton analysis tells us if there's any tooth size discrepancies between maxillary and mandibular teeth. So in this particular case, there was a tooth size discrepancy and IPR was needed on the mandibular for 1.3 millimeters and it was all scattered, as you can see. Now, after 21 steps in this particular case, which is the same one I just showed you, we get posterior open bite and we need a refinement. So this increases the treatment plan. And this could have been prevented by doing IPR of the premolars because the provider did not do the IPR on the premolars. And so this is a result because when you are not doing the IPR that is necessary, you are not correcting that tooth size discrepancy. And thus you might come up with those those results that you would not want, such as this open bite, and that you can't predict, and we could not predict because the IPR was requested in the treatment plan was not completed by the provider. So this is the results of not doing IPR, which I think is very good for you to see because there's a reason for IPR and when we request it. So when do we do IPR? We already touched on the why. When do we do it? And IPR needs to be done when it's feasible. That's the first point. So in this case, because we get the question of a lot of providers, can I just do IPR on the first step? Why do I have to have the patient back, let's say in step 6 and step 12, and do IPR in 3 different appointments when I could have done the IPR all in one step? And the reason for that is because you need to have straight access to that point of contact. In this case, you can see this incisor is rotated so much that you will not be able to get into that interproximal contact without causing damage to the tooth because this IPR would not be done correctly. So in this particular situation, we probably will have to do a little bit of expansion first, and then you will be able to get in a much more straight way into that interproximal contact, but that will probably take a few steps before we can get you there. And also remember to look at your treaty plan. We're gonna always highlight in red here when your step for IPR is, and obviously you're gonna see it in the PDF form. Like I said, you can see here number steps 12, IPR before step 12 in the lower arch. And obviously matching the PDF form to what you see in the treaty plan in step 12 here, it should match where the IPR needs to be done. How do you do the IPR? Now, I'm gonna start saying here at TruePredict, we don't recommend a specific brand that you can use of this or strips or kits, but know that it is the preference of the provider. Some of our providers, some of our most experienced providers don't use kits. They just use a burr and they just use the disc, and the size is up to them. Now, I always suggest for general dentists, it will be very beneficial for you to get, especially when you're just started, a kit for IPR. You can get this through your dental distributor, whoever is selling you, your materials, your instruments, etc. That person will have an IPR kit. It's very useful because it tells you 0.1 millimeter, 0.2 millimeter, 0.3, and then you don't have to guess. But if you're more experienced, obviously, you can either use the burr of your preference, which obviously will be more like a flame burr, and just the strips. Now, since the strips are not that wide, they're probably around 0.50 millimeters, I will say up to 2.2 millimeters, you can use the strips. If you need more than that, please use the disc or please use the diamond burr. Now, in this case, you can see this is our medical director performing IPR on this patient. She's first using the strips just to open the contact so she can have a straight access in there. And she's doing it enough until she feels comfortable. You can use floss to make sure it's open. And then she goes with the disc and she performs IPR. Now, IPR needs to be, it is a science. Obviously, it's not a guesstimate. There's a way to measure it, and it's important that we all measure how much IPR we're performing on patients. And I'll show you that in a second, but let me just first say that when you perform IPR, please break the contact. It is important. If you're not breaking the contact, you are not performing IPR. Teeth are not gonna move. You are gonna have a refinement and you're gonna have more chair time. So how much is too much? Obviously, gingival margin, getting to the gingival margin is not okay. Just until you break that contact, and we all know how that feels, especially because we're used to do that for composites and for crowns, etc. Break the contact. If you break the contact, you are good. So once again, how do you measure the IPR? You need a gauge. you need an IPR gauge. This might come in a kit. This might come separately. This tells you exactly how much IPR you have performed. Obviously, it is a science. As you do it more and more, you're gonna feel more comfortable of how much you're actually taking out. If you start slowly at the beginning, that's fine. You will eventually get there with practice. But if you have the gauge, you should be golden. And in this case, we see the amount of IPR we did was 0.3 millimeters, and you can see all the different values on the gauge. Is IPR safe? The big question. We're all scared about IPR. We're all taught in dental school, enamel is precious. Please don't touch it if it's not needed. But think about it. If we do restorations, they're needed. If we do IPR to correct malocclusions to help our patients have a better quality of life, whatever the reason is, IPR, IPR is needed in that case. Touching the enamel is needed. There is a lot of literature out there saying IPR is safe when performed correctly, safely, when you're gauging how much you're taking out, when you're breaking the point of contact. It does not lead to decay in the long term. Any questions on IPR at this point? Please feel free to ask questions. Either I'm being very clear or I'm being very unclear. Okay, let's keep going. So let's talk about auxiliary elements. Auxiliary elements are basically attachments, bite ramps, and torque controls. You might have different ones in other companies, but in reality, at 3D Printing, we believe in minimalism. We're gonna be believing in minimalism for IPR. We believe in minimalism for auxiliary elements too. So what is strictly necessary is not about being fancy. It's not about showing you different shapes of attachments, like 10 different shapes, 20 different shapes. It's about what actually works. And in this case, we can see the difference. I want you to be able to pinpoint how they all look like in your 3D plan. And I actually have a complete different webinar on this that actually lasts an hour. I'm gonna go through this real quick, but if you have questions on attachment and auxiliary elements and what each one does, please ask your sales representative to give you the link to my webinar. But in this case, we can see the bite ramps are these blue orbs in the back of the teeth, in the back of the anterior teeth. This other bluish, and sometimes they look triangular and rectangular because those are the only two shapes we use basically. Bluish shapes, they are attachments. And the little ovals in the neck of the teeth, they're purplish, those are torque controls. So this little table just give you a little summary of what each one does. The attachments, they help in aligner retention and the assistant to movement. The bite ramps do intrusion and root torque, and the torque controls root torque retraction of anterior and posterior teeth. Now for bite ramps and torque controls, please don't worry. You don't have to do anything. They are already included in the aligner. Please don't touch them. Please don't polish them. Please don't fill them with composite. They're just there to assist any movements. You don't have to worry about them. Now with the attachments, those are the ones that you're gonna be placing in those visits based on the PDF form that I showed you before. Now with that being said, we have conducted a study of 156 cases that we completed and to check the efficacy of the different shapes of attachments. And we have defined that really more than 2 or 3 shapes are not needed, but we're gonna be talking about that in a little bit. Now, torque controls, like I said, you can see here, they look like this small indentations at the top of an aligner that put pressure on the neck of the teeth. And the bite ramps, this is how they look. Like I said, this blue orbs and the back of the anterior teeth. And we're using to leveling the deep bites, crop bites, etc. And you can see how they look in the aligner right here. Now, we have basically two shapes of attachments, which is triangular and rectangular. And one question that we get a lot is, why do I need attachments and why only two shapes? And the reason for that is, first, attachments are needed. Attachments are needed, especially if you want predictable results, you want efficacy, and you want fast results, attachments are needed. Sometimes with the movements that we make, we tell you, for example, you don't need additional appliances, you don't need bands, elastics, but you are gonna need attachments. That's just a trade-off, because attachments are like a door handle. There's no way to open the door if you don't have a handle. So it's the same way. They engage with the aligner for you to be able to make those movements. You might get some movements with just the pressure from the aligner, but if you want more movement, if you want to resolve those a little more complex cases, you're going to need the attachments. Now, regarding the shapes, why only these shapes? And let me just say, semispheres, we do have semispheres. We almost never use them. We only use them as doctor requests them, and I'll let you know what they are for. But like I said, we only have basically horizontal and vertical attachments, and they are rectangular and triangular. And the reason for that is because we ran that study on 156 patients to see if changing the shape of an attachment to a more complex shape will actually increase the predictability of the treatment. And we determined that's actually not the case. And the reason for this is because when you add very complex shapes to a tooth, it takes you twice as long to polish those shapes, because you need to polish around the attachment, not touch the attachment per se. So when you have a half moon attachment, it's very hard to polish it. So it causes a lot of excess composite, which can affect the fit of your aligner and can cause refinements down the line. So please know, the shapes are going to give you the predictability you need. That's all you need. So how do you bond those attachments? And I'm just going to go through the bonding process because it's an issue we face with a lot of doctors. There's a lot of questions on it. Please always try the template and the aligner first. Why? Because if you don't, and you bond the attachments, and you then try the template and the aligner, and they don't fit, then it becomes a question of, is it the template and the aligner, or is the attachment? So make sure first the template and the aligner first fit, and then bond the attachment if they do fit. If they don't fit, which rarely happens, but if they don't fit, please reach out to us. Don't do anything to the aligners. Don't polish them. Don't try to cut them. Please reach out to us. Rinse and dry the template and the aligner, and then proceed to open the PDF report to make sure you are in the right appointment. You are following the steps that we're showing you on the PDF report, because remember, the PDF report is your roadmap. And isolate the teeth that will be receiving the attachments. Remember, attachments are composite. Follow your composite protocol, your regular composite protocol that you will follow for a successful restoration is what you need to follow with us when you're doing attachments. And please use packable or injectable composite. Don't use flowable. Flowable does not have the physical properties to withstand the amount of force that we're going to be placing on that composite. Depending on your technique, you might be able to get away with flowable, but why would you risk it if you have packable or injectable? And actually, packable or injectable would be easier to place on the template. So if you go to your case here and you open the treaty plan, once again, you're going to see the PDF report. It's going to give you all the steps. And in here, you can see the same steps that I detailed once again, so you can plan the attachment bonding process at the specific step. Now, like I said before, Please follow your composite protocol. It's the same exact instruments. The only difference is the template. And you can see this video that I'm going to show you in a second under your manual section 2, and it's called attachment bonding. So once again, you go to your manual section and you're going to open that video. And here we get the question 2, do I need to cut the template? I would say for this first step, no, please don't cut the template. It will be good to check first that it fits. If you are on step 12, because we're only giving you one template that has all the different attachments in it, I would say you might have to cut it because those teeth already move. So in that case, for it to fit, you might want to cut it. Now, another question we get is, do I need to lubricate the template? In this video, you're not going to see any lubrication because lubrication is actually not needed. The only reason why you might have issues with the attachment not bonding to your teeth is if you're not following the steps that I'm outlining here. But if you want to be extra safe, you can always buy food grade silicone spray. Food grade silicone spray you can acquire at different retailers like Walmart or Cabela's or Amazon, etc. So what you would do is you will put it in your felt tip and then you will add it just on the area of the attachments that are on the template. Just right there, very lightly, to make sure you have some lubrication so the attachments don't stick to the template. So in this case, you can see our medical director cuts the template because this is not the first step for this patient. She didn't lubricate, but you could do so like I said before. And then she's placing the composite only on the area of the attachments. Now, please don't underfill it. If anything, overfill it just a tiny bit, not too much. And then prepare the teeth like you would do for a composite. Make sure they're polished, there's no debris there. And just follow your regular composite protocol: etch, rinse, dry, light, etc. Curing, placing your bond. And then we cure once again, and we dry first, we cure once again. And then put the template in the mouth. Now this step is crucial. You see she's holding the plane with one hand, and then with the other, she is grabbing her cotton plier and just holding the attachment on the sides of the attachment and pushing the template against the tube very gently, not squeezing the attachment, but pushing the template against the tube. This is to maximize that fit. So, and then the assistant is curing very lightly for a few seconds, 5 seconds, and then we remove our hands and the curing process finishes because we ensure great adaptation when we use the cotton plier. Then we remove the template and then we polish. Polish is very important. Polishing is crucial. Please make sure you polish all around those attachments. You don't want any extra material. Extra material, 0.2 millimeters of extra composite are gonna make your aligners not sit, not fit, not track, and it's gonna lead to refinements. You see she's taking her time, and this video is actually sped up, polishing those attachments, around the attachment, not the attachment itself, but around the attachment. And she's making sure that it's flush against the tube, that nothing is around the attachments. And at the end, she is just rinsing, drying, and trying on the step, the aligner step, and you can see everything fits. I always suggest start from the front to the back when you're placing that step. And you can see no issues, everything is great. Now, what we don't want to see when you're bonding the attachments, look at all the extra material on those molars. You can see it around the second molar all over, like a little circle around the attachments. You can see it on the gingival margin of the first molar. Please make sure all that extra material is gone. What we want to see is this. You see the attachment very clear, the demarcation of the attachment, and then you see the tooth surface. there's no extra composite around this attachment. If you use this protocol, not only are the attachment not gonna stick to the template, they're actually gonna stay for a while because you might need those attachments throughout the whole time of your treatment. So in this case, this provider used the great composite protocol to bond those attachments, and you can see the attachments are still in place even after 30 months of treatment. Now, the last thing I want to say about attachments is never place attachments on veneers and crowns or any facial restorations. The reason for this is even though you might be able to bond those attachments to veneer and crowns, if you use hydrofluoric acid, you have a crown bonding kit, etc., you might damage that crown and that veneer when you remove the attachment. And you're gonna have a very unhappy patient at the end of your treatment. So if you wanna prevent that, if it's not in your plan to change the veneer or the crown or the facial restoration, please, in your prescription, at the very bottom of your prescription, let us know where those crowns, veneer restorations are so we can prevent placing attachments there. Any questions on auxiliary elements at this point? Okay, so this is Panama Canal. You're more than welcome to visit. Refinements, the hot topic of refinements. When, why, and how refinements. So when? One straight answer to when the tray doesn't fit, right? This is most likely, this specific case is a 14-year-old kid. This patient was not compliant. I must say teenagers are just, we all know teenagers for any, when we see teenagers for cleanings and so on, but for aligners, compliance is an issue with them sometimes. So that conversation needs to happen from the beginning with the parents and needs to happen with the teenager if they want clear aligners. So this patient was not wearing his aligners 22 hours per day. The protocol was still 40 days, but like I said, the issue was the compliance of the patient. So it's always a first thought, compliance. Most refinements are due to compliance, at least with Treated Predict are due to compliance. Now, let me just say here, you see this space of the aligner. If you have a step of one aligner and you see a space less than 1 millimeter, less than 1 millimeter here, usually doesn't mean a refinement. It means that at the end of that step, at the end of the 14 steps, the aligner will fit. Because remember, we're aiming to get to that movement. But if this space is more than 1 millimeter or 1 millimeter, then it means that you need a refinement. So the reason to figure out when do you need this refinement is to take a look at your treatment plan, is to take before and after pictures, and to check if the movements have been realized. I always tell the doctor, since you're only having this patient for 6 visits, right? Or less than 6 visits, I recommend taking pictures every single visit, at least intraoral pictures. That's what I'm saying, occlusal picture views. You don't need to take the whole thing because that serves several purposes. It serves the purpose of comparing the 3D plan step where you are to what is actually happening with your patient, to get any tracking issues early on, resolve and address, and also serves the purpose of showing the patient how things are moving and how long they have come in their treatment. And that actually says a lot about compliance, because when patients feel that things are changing, they're more likely to start wearing their aligners. So when an aligner does not fit, like I show you in the previous slide, the refinement should take place right away. Please don't wait. If that aligner is not fitting, things are not going to improve. Let's just submit for our refinement and I'll show you exactly what you need to do. But sometimes the aligner fits, but there's one tooth that is not tracking and you notice it right away. Let's say you did a lot of rotation on one canine, everything else seems to be tracking except that canine, which is kind of tracking, but you know it's a little lagging and it's not matching perfectly with the treaty plan. Then you have the option of waiting until the end of the treaty plan to submit for a refinement. So there's a difference of the aligner not fitting at all versus one tooth not tracking, which in that case, you have the option of waiting till the end of the treatment. So again, if an aligner is not fitting, and also if the refinement is needed before you get to step 12, most likely is due to compliance. It's not anything that you're doing, it's not an issue of the aligners, it's patient compliance. So in these pictures, we can see here that this was a step 1, and this was a step 6 of this patient. And in the first 12 aligners, which is usually expansion and torque, there's really not many difficult movements that should be reflected there. That's why we know that if this is not tracking, it's because most likely because of the patient. So in this treaty plan, we can see here that this molar was supposed to distalize much more than what we're actually seeing in the mouth. And this did not take place. And in this first lower left, in the central left incisor, we can see that the rotation and crowding correction did not take place versus in the mouth compared to the treaty plan. So very minor things. You can see you really need to take into account that when you take the pictures, you need to sit down and look at them to make sure things are tracking. But if you're suspecting they're not tracking, then a 2x2, check might be needed to make sure that you might need to change that. You might need to submit that for a refinement right away, or you can wait until the end. So why, like I said, lack of patient compliance, like I said before, incomplete IPR, which I already mentioned before, you didn't do the IPR till the point of contact, you didn't break that point of contact, or you didn't do the whole volume of IPR that was needed. Inadequate diagnosis, obviously, if you were not taking correct pictures from the beginning, your staff was not taking great scans, obviously refinements might be needed. Difficulty in movements, I'm going to show you that in a second, and lack of clinical follow-up. So I'm going to touch on difficulty movements right away because I feel like the first 3 points were already addressed. So this is not a guessing game for you. We're always going to be very straightforward with you, and we're going to give you all the information that you need. How do you know a movement is difficult? We are going to let you know. If you submit a treaty plan, our technician, first of all, is going to leave you a comment saying this, this amount of distalization, this amount of rotation of this lateral incisor of this canine is outside of predictability limits. What that means, what that phrase means, is that it's either too much movement for the amount of steps that you want to achieve this movement for, because you're not going to have this patient wearing 50 trays, right, indefinitely, or it violates anatomical boundaries and thus is unpredictable. That's one thing. One way you're going to figure out this is a difficult movement, because our technician is going to tell you. But also, if you open the plan movement data that is in your PDF report, going back to the PDF report, which is the roadmap for your treaty plan, you're going to see those numbers highlighted in red. So anything that is in red is outside of predictability limits. So which this means is that you might need a refinement, right, at the end of the treatment. We might not be able to achieve this volume. You might need elastics. We might not be able to achieve this volume without elastics, or this is completely violating the patient's anatomical boundaries, and thus you're going to have periodontal issues down the line. But our technicians will let you know which one of those three is. Also, lack of clinical follow-up. Even though the PDF form is the roadmap, like I said, to your 3D plan, and it's going to tell you when to see those patients, know that at the very least, you should see your patients every 3 months. We really think that 3 months is the key number to make sure things are tracking, to make sure your patient is being compliant, and to make sure that you are happy with what you're seeing in the mouth. And to take those pictures, like I said, to show your patient. So let's take a look at this case example. We can see at the end of treatment that the spaces between the upper left premolars are still there. So there's a refinement. You can see here compared to the 3D plan. So in this case, taking these pictures help the communication with the patient, because patients obviously are not going to know the spaces are still there. They might notice, they might not notice if the space is small enough. They're just going to know, well, look, how long have I come? I have resolved this crowding. The arch form is much more acceptable. But at the end of the day, these spaces are still there and they need to be closed. And we all know why this need to be closed for periodontal health, etc. So this helped the patient accept the refinement much more easily because they're already noticing there's an issue compared to the 3D plan, but they also notice that there has been a big change. So there's already trust put in you that you know what you're doing. So in this case, the reason for the refinement was incomplete IPR. The provider didn't break the point of contact. I'm going to show you that in a second. And then 30 aligners were done before the refinement was needed. So in here you can see, even in the new scan that the provider submitted for the refinement, you can see the point of contact was not broken. So more IPR was needed to break that point of contact and to correct this lack of distalization. So this is the same patient, lower arch. The refinement was needed because this canine didn't track. You see, everything else looks pretty good, but this canine here didn't achieve the amount of rotation of 30 degrees that we had predicted. And you know, this is a good point of conversation with your patient. You get these pictures up and you say, are we okay with this? Maybe as a provider, you know, because the amount of rotation that is left that is actually needed is very minor. So maybe the patient is not even going to go for a refinement. Maybe you as a provider feel happy with this result. But in this case, the patient did want the refinement. And the reason for the refinement, once again, was incomplete IPR. The doctor didn't break the point of contact in the IPR that was requested before, and thus the IPR was needed once again to break that point of contact for incomplete rotation of number 27. Now we're going to touch a little bit on open bite because it's a hot topic nowadays. And there's a lot of literature outside on open bite, a lot of back and forth, but here at 3D Predict, we know the causes of open bite and we can definitely address so your cases don't end up in an open bite. So the causes for an open bite after aligner treatment are basically 4. Expansion without control, loss of enamel structure due to erosion, attrition, etc., incisor stork and tight overjet, and mandibular misalignment, which is called a bite jump. And I suggest, you know, after this webinar, you will go read a little bit about bite jump because it causes a lot of questions. I'm going to try to be as clear as possible. I think I might have to develop a webinar just on bite jump soon, but I'm going to try to give you all the information I can in the limited amount of time we have tonight. So uncontrolled expansion. So in here you can see this patient before treatment. This was a refinement step which you can clearly see the open bite that didn't exist before. And this was actually what should have looked like the patient at the end. So what did this happen? It happened because of expansion without control. When you don't know where you are, like I said, you don't know where you're going. So it is very common that when those molars reach the cortical plate limit, these costs are gonna, they don't have anywhere to go. So the buccal cost will intrude. The lingual cost will intrude, and then you're gonna see a flare of the buccal cusp, which is gonna give the appearance of an open bite. You can see it in this case too. Patient didn't have an open bite at the beginning of treatment. Patient ended up in an open bite. Once again, uncontrolled expansion. We don't know where that cortical plate is. That's why I always suggest, if you can submit a CBCT, please submit a CBCT. The second reason for an open bite is a loss of enamel structure on cusp. Obviously, I don't think I need to explain this. This patient already had this flat cusp on that molar. When we finished the case, this patient should have received a crown, probably just a crown, to close this open bite. The third reason is angle of incisors and tight overjet. So when you have this tight overjet, and when you look at the last step of the treaty plan, we're always going to try to give you balanced occlusion. But please know that we're following your prescription once again. So if your prescription is calling for a tight overjet at the end of the treatment, you're not taking into account the width of the aligners. That's why when you see treaty plans, usually you're always going to see a little bit of overjet and a little bit of overbite because you're taking into account the width of the aligners. But if you ask us to make a tight overjet and you don't see any contacts in posterior teeth, you are going to have an open bite at the end of treatment because this is preventing those teeth from touching, those anterior teeth. The fourth reason for open bite at the end of treatment is what is called the bite jump. So this case is a class 2 patient, and you can see here at the end of treatment, the doctor had planned expansion and distalization for this particular case. But at the end of treatment, what happened is that because the doctor didn't take into account that the teeth already had tight overjet, this ties back to my previous point. At the beginning of treatment, the mandibular jaw was locked by the maxillary. So this was in a tight bite. When the doctor created expansion and distalization, he released the upper jaw, which allowed the facial muscles and the masseter to relax. That causes mandibular misalignment because now the muscles are rearranging, and thus the mandible is moving, and nobody can predict how the mandible is gonna move now that it has been released and it's not in that tight overjet that it originally was. So because of this, we ended up with an open bite. The way this could have been prevented is if the doctor had planned for a little bit of more retraction of the upper teeth to make sure that when the bite jumped, this and the posterior open bite would not have been so prominent. Now know that even if the doctor will have planned, like I said, for that retraction of the upper teeth, bite jumps are unpredictable. Like I said, we are moving teeth. We are not dealing with muscles. No aligner company knows how the mandible is gonna end up. And thus it is very difficult to give you an accurate, like a 100% accurate treatment plan. In that case, refinements are usually needed, but it doesn't have to be this amount of open bite if we actually plan it much better from the beginning. And we take into account that we were starting with already a tight overjet. This also happens with open bite cases because we're doing extrusion of posterior teeth and we're doing intrusion of anterior teeth, and that releases the mandible again, and thus it starts moving whichever way. So how do you submit for a refinement? For us, you go to your patient account, you click on order correction, and you submit intraoral pictures, extraoral pictures, scans. So you follow the same steps that you follow when you submitted your patients from the beginning. It is very important to have those pictures and scans because you are producing a new treatment plan basically. So we need to have all the information possible to be able to give you a proper refinement. And we get the question of, what do I do until I get the refinement? Please keep your patients on the last trays that fit. So if this tray is not fitting, but the previous tray fit, please keep your patient on that tray until you receive the refinement. And if you have questions about the refinement, this will be in our manual section soon. So as a summary, because we cover so much information, so much material, please pay attention to detail. Diagnosis, case selection, the prescription, how you communicate with the technician, how you review your treatment plans, what are your goals? Please keep into account when you're reviewing the treatment plans that you are looking at your goals, not a perfect occlusion, at your goals and at your patient's goals. Those are the keys to finishing a case in only 6 visits. Also, always have the PDF report handy, whether you're looking at it in your 3D plan or you're looking at it in the printout that we're giving you in the first case of the aligners. We will always add IPR as minimal as possible. IPR, attachments, refinements, everything with 3D Predict is minimal. We try to minimize burdens to you, appointments, patient aggravation, staff aggravation. Also, for your IPR, please use the gauge. It is important to know how much you're taking. Don't guesstimate what you're doing. And once again, we only need 5 shapes of attachments. Like I said, because we're very minimalistic, and you as a provider should review the movements projected in the 3D plan that have been completed at every step. Every time you have the patient in the chair, take those pictures, show it to the patient, go to the 3D plan, make sure everything is tracking so you can make the decision of a refinement is needed or not needed and when to submit it. And know that the refinements why are gonna take you into the when. So if you know why you need the refinement, you're gonna know when to submit it. Can I wait until the end of the treatment? Do I need to submit it now?